Hello, can you sit please? I'm going to do the objective examination of you. Okay. Please straight to the waist.
Number 1. General condition. General condition of the patient is satisfactory.
General condition of the patient is satisfactory. Variants of general condition of the patient may be satisfactory condition, middle grave condition, grave condition, agonal state.
Number 2. Conformity of appearance and age.
How old are you? I'm 23.
Patient show conformity of appearance and age. He doesn't look younger or older. There are conditions in which the patient looks older. Syndrome of flab skin, cutis laxa. There are conditions in which the patient looks younger, for example, mitral anonism, angioplastic infantilism, cachexic infantilism, celiac infant, dysthyroidal infantilism, renal and hepatic infantilism, intestinal infantilism, pituitary infantilism. Infantilism is a condition in which the mind and body make slow development. Individual fails to obtain adult characteristics. Nanism occurs when an individual person is short in stature resulting from a medical condition caused by abnormal growth.
Number 3. Consciousness.
What time is it now?
4:30.
What's the day of the week?
It's Wednesday.
Month.
It's June
What year is it?
2014.
Where are you now?
In the hospital.
What's the president of Russia?
Vladimir Putin.
What's the date of the Second World War?
It's from 39 to 45.
Can you count from 10 to 1?
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
How old are you?
I'm 23.
Can you name 3 objects here?
Alright. Window, bed, and chair.
Patient is alert according to Glasgow Coma Scale, which is 15, oriented in time, place, and personality, without limited intelligence or abnormal beliefs. Calculations are normal. Glasgow Coma Scale. Scores for eye opening, motor, and verbal response. Glasgow Coma Scale. Response. Check eye opening. If open eye spontaneously, 0.4. Open eye in response to speech, 3. Open eyes in response to painful stimulation, 2. Does not open eyes in response to any stimulation, 1. Motor response. If patient follows commands, 6. Makes localized movement in response to painful stimulation, 5. Makes non-purposeful movement in response to noxious stimulation, 4. Flexes upper extremities or extends lower extremities in response to pain, 3. Extends all extremities in response to pain, 2. Makes no response to noxious stimuli, 1. Check verbal response. If patient is oriented to person, place, and time, 0.5. Converses may be confused, 4. Replies with inappropriate words, 3. Makes incomprehensible sounds, 2. Makes no response, 0.1. Coma. The full loss of consciousness including loss of reflexes. Deep sleep-like state from which the patient cannot be aroused, despite repeated painful stimuli. Patient remains unrousable with eyes closed. No evident response to inner need or external stimuli. Glasgow Coma Scale. Scores for eye opening, motor, and verbal response. Variants of consciousness of the patient may be alertness, awake, aware of self and the environment. When spoken to in a normal voice, patient looks at you and responds fully and appropriately to stimuli. Lethargy. When spoken to in a loud voice, patient appears drowsy but open eyes and looks at you, responds to questions, then falls asleep. Obtundation. When shaken gently, patient opens eyes and looks at you but responds slowly and is somewhat confused. Alertness and interest in environment is decreased. Illusions, misinterpretations of real external stimuli. Illusions may occur in grief reactions, delirium, acute and post-traumatic stress disorders, schizophrenia. Hallucinations, subjective sensory perceptions in the absence of relevant external stimuli. The person may or not recognize the experience as false. Hallucinations may occur in delirium, dementia, post-traumatic stress disorders, schizophrenia, and alcoholism. Abbreviated mental test. Ask time, day of week, month, year, age, place, names of 3 objects at 2 minutes, dates of Second World War, name Prime Minister, count backwards from 20 to 1. Sopor. Unusually deep sleep from which the patient recovers only for short periods of time when called loudly or roused by external stimuli. Reflexes are preserved. Paget's disease, excessive reabsorption of bones by osteoclasts and compensatory disorganized deposition of new bones, enlarged cranium in frontal and parietal areas.
Number 4, posture and gait.
Can you take some steps away, please?
Posture of the patient is free active without pathological gait.
Spastic hemiparesis, associated with lesion in corticospinal tract as with stroke. Description: one arm is held immobile and close to the side, with elbow, wrist, and interphalangeal joints flexed. The leg is extended, with plantar flexion of the foot. On walking, the patient either drags the foot, often scraping the toe, or cycles it stiffly outward and forward. Scissors gait, associated with bilateral spastic paresis of the legs. Description: the gait is stiff, each leg is advanced slowly, and the thighs tend to cross forward on each other at each step. The steps are short. The patient appears to be walking through water. Steppage gait, associated with foot drop, usually secondary to low motor neuron disease. Description: these patients either drag their feet or lift them high, with knees flexed, and bring them down with a slap onto the floor, thus appearing to be walking up stairs. They are unable to walk on their heels. The steppage gait may involve one or both sides. Sensory ataxia, associated with loss of position sense in the legs, as from polyneuropathy or posterior column damage. Description: the gait is unsteady and wide-based. These patients throw their feet forward and outward and bring them down, first on the heels and then on the toes, with a double tapping sound. They watch the ground for guidance while walking. With eyes closed, they cannot stand steadily with feet together, and the staggering gait worsens. Cerebellar ataxia, associated with disease of the cerebellum or associated tracts. Description: the gait is staggering, unsteady, and wide-based, with exaggerated difficulty on the turns. These patients cannot stand steadily with feet together, whether their eyes are open or closed. Parkinsonian gait, associated with the basal ganglia defects of Parkinson's disease. Description: the posture is stopped with a head and neck forward and hips and knees slightly flexed. Arms are flexed at elbows and wrists. The patient is slow in getting started. Steps are short and often shuffling. Arm swings are decreased and the patient turns around stiffly, all in one piece. Gait of older age, the aging process. Description: speed, balance, and agility decrease with aging. Step becomes short, uncertain, and even shuffling. The leg may be flexed at hips and knees. A cane may bolster lost confidence.
Number 5, look at the face.
Face is calm, without features of suffering. For the conclusion of specific diagnostic face, it's necessary to examine features of face, head, and neck. Anemic face in case of B12 deficiency, Addison-Birmer anemia. Slightly puffy, wax dull, very pale face with yellowish tint and seemingly translucent skin. Leprosy. Face of the patient in Hansen's disease. Notice the loss of the eyebrows and the nodules in the cheeks, nose, and ears, as well in the eyebrows. Parkinson's disease. Face of the patients in Parkinson's disease show decreased facial mobility, blunt expression, mask-like face with decreased blinking and characteristic stare. The neck and upper trunk tend to flex forward. The patient seems to peer upward toward the observer. Oily skin. Rhizus sardonicus in tetanus. It is sustained spasm of facial muscles. Aortic face. In aortic face, skin is pale, and many signs are found in association with aortic regurgitation. For example, Quincke sign, capillary pulsation in the nail beds, Demoset sign, head nodding in time with heartbeats. Corrigan signs, prominent carotid pulsation, Landau-Field sign, prominent alteration, constriction and dilation of the pupils. Corvisart's face. It is associated with cardiac insufficiency. Face is edematous, pale yellowish with cyanotic hue, half open mouth, cyanotic lips, dull eyes, sticky eyelids. Mitral face. Prominent rosy cheeks with a bluish tint, associated with mitral stenosis. Acromegaly. Results of excess growth hormone production by the anterior pituitary gland. Cushing face. Cause may be excess steroidal use, adrenal hyperplasia, adrenal neoplasia. It is also known as moon-like face. Facies basedovica in hyperthyroidism. Many signs are found, for example, Van Graff sign, slag of upper eyelid in downward rotation of the eyes, Dalrymple sign, widened palpebral opening, Selvage sign, hair blinking of lids, Rosenbeck sign, tremor of eyelids, Geoffroy sign, lack of wrinkling of the forehead when patient looks up, Moebius sign, inability to maintain convergence of the eyes. Facies basedovica in hyperthyroidism. Many signs are found, for example, Van Graff sign, slag of upper eyelid in downward rotation of the eyes, Dalrymple sign, widened palpebral opening, Selvage sign, hair blinking of lids, Rosenbeck sign, tremor of eyelids, Geoffroy sign, lack of wrinkling of the forehead when patient looks up, Moebius sign, inability to maintain convergence of the eyes. Dull puffy face in hypothyroidism. Edema pronounced around the eyes, loss of outer 1/3 of eyebrows. The presence of a bluish on a pale face resembles the appearance of a doll. Bright's face, found in patients with kidney disease, shows edematous face, swelling around the eyes, slit-like eyes in the morning, often pale. Mongoloid face in Down syndrome. It is congenital disease which gives mental retardation, small anterior-posterior cranial dimension, prominent medial epicanthus, flattened bridge to the nose, gaping mouth, broad fissured tongue. Neurofibromatosis in Recklinghausen disease. Hereditary multiple pedunculated flesh tumors distributed along nerve trunks. Café au lait pigmented macules. Face in Paget's disease. Osteitis deformans. It is a chronic disorder that can result in enlarged and poorly shaped bones, excessive reabsorption of bone by osteoclasts and compensatory disorganized deposition of new bone, enlarged cranial in frontal and parietal areas. Amiodarone use may result in deep blue discoloration around malar area and nose. Hypocratic face in advanced peritonitis. Eyes are sunken, temples collapsed, nose is pinched, crust on the lips, forehead is clammy. Paget's disease. Excessive reabsorption of bones by osteoclasts and compensatory disorganized deposition of new bones. Enlarged cranium in frontal and parietal areas. Myotonic face results in wasting and weakness of muscles of face. Patient has characteristic features as long face, facial weakness, dropping eyelids, open triangular shaped mouth. Turner syndrome. It is chromosomal abnormality in which all or part of one of the sex chromosomes is absent or has another abnormality. It may show typical features, for example, down-slanting eyes, droppy eyelids, prominent earlobes, crowding of the teeth, and short neck. Blue blotter's face in chronic bronchitis. These patients were sometimes called blue blotters because of cyanosis present in the later stage and because of the associated edema of right ventricular failure. Patient is overweight, edematous, and cyanotic. Facies pneumonica, hyperemia of the cheeks more pronounced on the affected side, participation of the nostrils in breathing, herpes nasalis and labialis, central cyanosis. Pink puffer face in emphysema, lips tightly opposed at height of inspiration, lips held narrowly apart during expiration, tachypnea with prolonged expiration through pursed lips, expiration with grunting sound.
When you feel pain, tell me, okay? Okay.
By inspection of the head, we may conclude that the head size is normal, not enlarged nor decreased, no visible deformities and tremor. No other disorders are present. Demoset's sign is negative. Palpation of head is painless, with no scars, depressions, and masses.
Trigonocephaly is a congenital condition of premature fusion of the metopic suture, leading to a triangular-shaped forehead.
Hydrocephalus.
Brachycephaly, head disproportionately wide, back of head is flat, height at the back of head is increased, bumps bulging above the ears, face may appear small relative to head size. Hypertelorism is abnormally increased distance between two organs or bodily parts, usually referring to an increased distance between the orbits, orbital hypertelorism. In this condition, the distance between the inner eye corners as well as the distance between the pupils is greater than normal. Normal, anencephalus, microcephalus, hydrocephalus. Normal infant head shape, brachycephaly, plagiocephaly, scaphocephaly. Oxycephalus, usually associated with other congenital defects and the stigmata of degeneration. The skull is domino-shaped with bulging temporal regions. The deformity was present at birth. It is generally associated with esophthalmos and pupillosis, frequently with other ocular abnormalities. Some children are mentally normal. Hydrocephalus implies an increase in the volume of cerebral spinal fluid, occupying the cerebral ventricles. This usually is a result of impaired absorption but may occasionally be due to excessive secretion. Midfacial hypoplasia. The center of the face develops more slowly than the eyes, forehead, and lower jaw. When mild, this is generally considered to be a normal, harmless genetic variation. In more severe cases, however, the condition is so pronounced that both appearance and health may be affected. Scaphocephaly. Head is disproportionately long, width of head is narrow, side of head may appear flat, forehead may appear squared-shaped, common in premature infants positioning inside line in the NICU, baby's head tends to fall over to one side or other when lying down, may impact ability to develop neck extension against gravity and midline head and neck control. Head scars. Plagiocephaly. Asymmetric flattening visible at back of head, size of head and or forehead. Parallelogram shape from a bird's eye view. Ears may not symmetrically align. One eye may appear smaller. One cheek may appear fuller. Asymmetric forehead. Top of head may slope down one side. Head fractures. Microcephaly is a neurodevelopmental disorder whereby a person's head is smaller than average for that person's gender and age. It is a birth defect that affects a child's learning development, since their head is smaller, allowing less room for growth of the brain. Anencephaly is the absence of a major portion of the brain, skull, and scalp that occurs during embryonic development. It is a cephalic disorder that results from a neural tube defect.
Nose.
Nose size is normal with no deformities, herpes nasalis, and ulceration. Nasal mucosa is pinkish with no swelling. There's no visible nasal polyps and no septum deviation. Wings are not participating in breathing.
Examination of the nose. Inspect the anterior and inferior surface of the nose. Gentle press on the tip of the nose with your thumb usually widens than the nostril, and with the aid of a pen light or otoscope light, you can get a partial view of each nasal vestibule. If the tip is tender, be particularly gentle and manipulate the nose as little as possible. Note any asymmetry or deformity of the nose. Tenderness of the nasal tip or eyelid suggests local infection such as furuncle. Deviation of the lower septum is common and may be easily visible. Deviation seldom obstructs airflow. Inspection inside of the nose. With an otoscope and the largest ear speculum available, tilt the patient's head back a bit and insert the speculum gently into the vestibule